Hi, I'm Dr. Jocelyn Idema, Orthopaedic Spine Surgeon with Advanced Orthopaedics Rehabilitation. Artificial disc replacement is changing the way we treat arm pain. Before we get started, if you're watching from Facebook Live, make sure you hit the like and share buttons if you can hear me loud and clear. And drop me a comment. Let me know where you're watching from. So before we start, none of this is considered medical advice. Please talk to your medical provider or schedule an appointment with me for any specific questions. Today, we're going to briefly discuss how the neck works, the progression of arm pain, what happens when a cervical disc wears out, what are my treatment options, what are the risks and benefits of a cervical disc replacement, and what can you expect after surgery. So a normal, healthy neck, as demonstrated by this fake neck, has 7 vertebrae, discs in between, which are the shock absorbers. It allows for movement both forwards and backwards, known as flexion and extension, side to side, which is our lateral bending, and rotation from left to right. Degenerative disc disease results from loss of hydration to the disc. The disc thins out and gets less flexible. It can have tears and cracks, and it may actually develop into a disc herniation. The infrastructure overall begins to compress the neck. Disc herniations and stenosis can happen and place pressure on the spinal nerves. Spinal cord irritation and spinal nerve irritation can decrease your sensation in your arms and your hands. It can also cause weakness of your arm or your hand. This is generally called a radiculopathy. Nerve roots can become pinched, which can cause arm pain, weakness, tingling down the arm into your hands, and especially pain between your shoulder blades and the upper portion of your back and neck. Again, some signs and symptoms. Usually the pain doesn't begin as the first symptom. It's usually numbness that people can ignore. Then the tingling or the pain starts, weakness can start. It can happen in one or both arms, pain radiating from your neck into your shoulder or from your shoulder up into your neck and all the way down your arm. So we start, as always, with the conservative treatment. That can be anti-inflammatories, physical therapy, chiropractic care, neck injections, and ultimately surgery if all conservative measures fail. So some surgical indications. This is usually reserved for adults anywhere between 20 and 50 years old. Obviously, people who have failed conservative treatment that we have already tried, disc damage, but with normal neck joints. So when we talk about that, what we're talking about are the joints back here in the neck that can develop some arthritis. I'll talk about that later when we talk about the actual surgery. Arm pain with or without neurological symptoms, meaning weakness or no weakness. Some surgical contraindications for cervical disc replacement: infections, any metal allergies, trauma, osteopenia or osteoporosis, because the prosthesis has a risk of fracturing those vertebrae, or severe degenerative joint disease of those neck joints. So surgical options. There are only 2 FDA-approved cervical disc replacements or cervical disc arthroplasties. The first is the Zimmer Biomet Mobi C. And here's our cute little neck. I'm going to move that a little bit closer for you. So again, this allows for normal motion, forward and backwards, side to side, and rotation. If we open this up, what you'll see is there's a metal top and bottom with this little plastic kind of polyethylene that floats around in there. And that's what mimics the normal motion of the neck. So that's the Mobi C. The second one is the Medtronic Bryan disc. So looks similar insofar as there's a metal top and bottom, but inside is more of a silicone. It's filled with saline or water. And it allows, again, for that side-to-side motion, front and back, and rotation. Again, mimicking the normal motion in the neck, or at least trying to the best that we can. Some of the risks with a cervical disc replacement: when we perform this procedure, we have to go in from the front. We remove the disc and any of the bone spurs that are pressing on those nerves. And some of the bigger structures that run through the front of your neck are your breathing tube, known as your trachea, your swallowing tube, known as your esophagus. We have to move those out of the way. And then there's these big vascular structures on the side, the carotid artery and the jugular vein. We have to move those to the opposite side. Any of those can be injured while we're working. So those are one of the major risks. Once we remove the disc and we're as far back as the spinal cord, the covering around the spinal cord is something that we see, and it's called the dura. And that can be injured if there are any sharp pieces that we don't quite remove. That sort of thing can cause a tear, damage the spinal cord itself, but it can cause the patient to leak cerebrospinal fluid and they get a horrific headache. So we try and avoid that at all costs. Some of the other risks are obviously infection. Anytime you make an incision on the body, you risk an infection. So we handle that with antibiotics. And then just from the breathing tube that has to be pushed down and us moving the breathing tube to the side, you can get some hoarseness and a little bit of swallowing difficulty afterwards. The final risk is some patients' anatomy, even though on the x-rays and the MRI, we may think it looks good for cervical disc replacement. That doesn't really, we don't know for certain until we get in and start working. And so there's always the possibility that while we're in there doing surgery, if things aren't looking quite right to place this prosthesis, we would have to resort to a fusion. That's where we put the plate and the screws in so that that segment doesn't move anymore. But some of the nice benefits, if you are a candidate for a cervical disc replacement, is we can match the disc height that you've lost to the normal ones, usually above and below. If you have a large disc herniation, we take that out, your arm pain gets significantly better. Even your neck pain can get significantly better. A lot of patients don't realize that their shoulder blade pain is actually not coming from their chest or the upper part of their spine. It's actually referred from their neck, so that will improve as well. It may not improve your neck motion, but the biggest benefit is it will not cause the discs above and below to start to go bad, which is what unfortunately happens with a cervical fusion. Once we stop the motion at these two levels, this disc and the one below kind of have to work a little bit harder when the patient's moving their neck, and that can cause these two discs to start going bad. So if this disc gets replaced, like I showed you on those other models, it'll maintain that normal motion, and hopefully the attempt is to not cause that cascading degenerative effect on the discs above and below. Obviously, the whole point of surgery is to get you out of pain and get you back to doing what you would like to do. Again, just to remind you, leave me some comments below, some of the things that you like that I talked about, some questions you might have, and of course, what other things you might like me to talk about in the future. So obviously some precautions that we go through prior to any surgery. We make sure that your medical doctor says it's okay. If you have a cardiologist, we have to get their approval as well. If you're a diabetic, we want to keep those blood sugars as controlled as possible. If you are a diabetic, you've probably heard of the blood test called a hemoglobin A1C. And some of the newest material out recommends for basically almost any surgery that your hemoglobin A1C be at least 7.5 or lower, as close to that number 6 as possible. If you're heavier, this surgery can be very difficult, may not be as easy to do as a cervical fusion. So it's always beneficial to be as to lose as much weight as possible. But we know there are some kind of there can be some issues with trying to do that, and we can work around those. The other things that can prevent you from being a candidate is if you've had previous surgery on your neck and you've had some fusion that maybe went on in the back, this isn't going to work for you, or some previous trauma that may have caused a fracture or some malalignment, or if the bone itself has been damaged in some way where that prosthetic won't fit exactly how we need it to, because there's nothing to hold this in place like screws. It's more of what we call a press fit. We have a really scratchy end of the metal that we place into the bone, and it kind of just grips it until it can grow into the bone, but that takes time. So some of the outcomes for cervical disc replacement, after 5 years, this is some of the literature, 83% of cervical disc replacement patients were able to improve the range of motion in their necks than they had when the pathology was still in their neck, the disease was still in their neck. 95% of all cervical disc replacement patients, compared to 91% of cervical fusion patients, showed similar or improved neurologic function after 5 years. So we already went through how does fusion compare to the artificial disc replacement. Now let's talk about, if you are a cervical disc replacement candidate, how you prepare for surgery. So we talked about our medical clearances and preoperative workup. If you're older, we usually get an EKG and appropriate labs so that anesthesia knows what they need to do with their anesthetics. Preoperatively, we do have a type of wash, a chlorhexidine wash that you're going to bathe with, or wipes that you wipe the area that we're going to operate with. And our attempt is to cut down on any surgical site infections. It's really important. Now, what can I expect after my cervical disc replacement surgery? So the nice part about this, and pretty much any cervical procedure, is if you're having that really bad radiating arm pain or shoulder blade pain, when you wake up in the recovery room, that pain should be about 90% better. So that's a good benefit. Your neck's going to hurt, your throat's going to be sore. So we tell patients to stick to things that are really easy to swallow. Tepid soups, shakes, scrambled eggs. You know, you want to stay away from your hamburgers, your pretzels, anything that's really kind of gritty and dry. Are you going to be in a neck collar? Usually we place patients in a soft cervical collar for about 2 weeks because we want to get that motion going. We don't want this to turn into a really pretty prosthetic that ended up fusing. We want you to be able to start moving your neck, but not for those first 2 weeks. We need the incision to heal. We need all of the swelling to calm down, and then we can remove that neck brace. The incision site and dressings, usually we have a dressing that you're going to change after about 48 hours. I use what's known as kind of medical super glue. So you're able to take a shower and then you just kind of pat it dry. And if you get one of those really big Johnson & Johnson Band-Aids, it'll fit nicely over top. It'll also prevent the collar from kind of rubbing on your incision. At your 2-week post-op, we do get where things have ended up. Hopefully nothing has moved. And after your 6-week follow-up, we get x-rays of you moving. So we get x-rays of you flexing and extending. And the nice part about that is when I show you your films, you'll get to see that your neck is actually still moving in a normal way. So some of the common questions I get: when can I shower? So typically about 48 hours after surgery, you can shower. When can I drive? Well, you can't be in a collar and try and see in your blind spots or look over your shoulder to back up. So you got to be out of your cervical collar first. And then I tell patients to go to a parking lot and practice. You know, your neck hasn't moved in that manner in about 2 weeks. And if you've been really stiff even prior to surgery, it probably hasn't moved that well even prior to that. So go to the parking lot, drive around, back up, look over your shoulder. If everything goes fine, you can drive. When do we start physical therapy? So typically at 2 weeks, we're going to start you doing your own exercises. At 6 weeks, if patients are still kind of hypersensitive as far as their back of their neck, which is a very common area to have postoperative pain, we'll start them in outpatient physical therapy. But at 2 weeks, we just start some gentle range of motion, kind of waking those muscles up, getting your neck used to the fact that it can move again, and just start slowly. If there are any questions that you have that I haven't covered that you've thought of, please leave them in the comment section below. So again, the nice part about cervical disc replacements, they have great outcomes. They're actually becoming more of the standard of care for younger patients with single isolated levels of disc degeneration or single levels of disc herniations, whether they be caused by a motor vehicle accident or on-the-job injury or just wear and tear over time. They allow the neck to maintain its normal motion. So we're hoping we're cutting down on those degeneration above and below. And again, these can also be done in an outpatient setting. So I hope this answers some of the questions that you might have had in regards to neck and arm pain and these advances in the techniques that are coming out. So make sure to join me next time for more of my live webinars and Facebook Live videos. Remember to check my Facebook page at Dr. Jocelyn Idema for updates and more Facebook Live topics. See you next time.